Moving on to our next speech, I welcome Dr.A.K. Jayachandran, Chief Consultant Neonatologist, Neobless, Maulana Hospital, Perinthalmanna, IAP Neo Chapter, South India Coordinator with 10 years of UK training and Secretary NNF Kerala. Please come forward, sir.
Good morning. Warm greetings from IAP Kerala, NNF Kerala, and my unit, Neobless.
The newborn was constitute normal and abnormal. Of course, we have to know what is normal, then only we will know what is abnormal. Especially in case of newborn, because after the term expectation, the whole family, the friends, relatives, everyone will be looking at the child very closely. Microscopically, they will be analyzing and they will be coming out with so many queries. So you should know what is normal, then only you can tell which is abnormal. And also, the abnormality also in the newborns are very subtle. So if you don't know what is abnormal also, is a problem. We will have a very good session from Dr. Jayachandran. Over to Dr. Jayachandran.
Thank you, Chairpersons. Good morning and warm greetings from IAP Malappuram, NNF Kerala, and my unit, Neobless. As Chairperson rightly mentioned, we all are experts in this field, very senior pediatricians. We all know what is normal and we all know what is abnormal. Then what I have to do here? The reason behind this talk is the distinction between normal behavior and early signs of illness is difficult in newborn period, especially in preterms or late preterms, which means 34 to 37 weeks. Any newborn's condition can deteriorate very rapidly. There are lots of non-specific clinical features in newborn period. Signs do not always help in identifying the etiology, like whether it is infective, respiratory, cardiac, or even metabolic. All can present in the same way. But there is a window period during which early signs of deterioration can manifest, but unfortunately, it is often missed. So there is a relevance here. And as we just heard, the mortality among sick neonates is very high. In India, about 43% of the IMR is contributed by the newborn period. Early identification and prompt and timely treatment or referral is important, which will significantly influence the outcome. So the areas covered: newborn examination, especially the heart murmur, the importance of saturation check, respiratory problems, and importance of checking red reflex. And also I will be covering about very common problems like jaundice, vomiting, fever in a neonate, and a single slide about neonatal skin conditions. So newborn examination, we all used to do in our day-to-day practice, but it's time to just think and again reflect at the end of this talk, how much time are we spending for the newborn examination? Does it include picking up the hidden dangers in newborns, or are we paying sufficient attention to that? Is an ideal way of doing newborn check. We all taught different methods by different professors in medical colleges. But I'll suggest better we have a good system, and it is one area which is worth spending time on it. So I'll go into details. You know, when I thought after coming from England here, what system I can adopt here for a newborn examination. So this was a solution. After 1 year of working here, we designed this stamp system. It covers basically all the routine thing we do, but a little bit of extra points. And one extra point which we are routinely doing is checking at the red reflex and checking at the femoral pulse and routinely doing OAE. I know we all also do bilirubin check and thyroid before discharge. Saturation monitoring at predictal, any right hand, and any foot which is postdictal. And always we should have birth weight and discharge weight with head circumference, and name, sign of the doctor with the date and time. So if you can take one point from this talk, this may be this slide. Because I know we all do baby check, but there are some hidden dangers which we can pick up by following the chart, especially the red reflex, femorals, saturation, these three things. So I will go into a little bit of details. Also, we will document there is no CTV, there is no cleft palate. Cleft palate is hidden danger. So coming to the heart murmur. Soft heart murmurs are very common in newborn period, and even innocent murmurs can be heard widely over the chest because of the lack of fat. Many infants with murmur do not have any structural heart disease. That's an important statement. Murmurs can be normal or abnormal, or physiological or pathological. Normal newborn examination and absence of murmur does not guarantee that no congenital heart disease. When we get referral and when we ring back the referring doctors that this baby they may be referred for respiratory distress. When we ring back and say that this baby hasn't got a congenital heart disease, the first sentence the referring doctor used to say is, when I examined, there was no murmur. But absence of murmur does not exclude congenital heart disease. But evaluation of heart murmur is important because of potentially adverse outcome when serious critical heart disease remains undetected. Dr. Kamath sir just mentioned that about 8% of the neonatal or infant mortality in India is due to congenital heart disease. Especially when Kerala is going towards the single digit IMR, the one or two areas which we have to more concentrate is screening for inborn errors of metabolism and screening for congenital heart disease or other congenital anomalies. Because in Western countries, there's a system there. We were still focusing on how to prevent infection, but Kerala has come to a little bit far away from that area. If we can pick up IEM early, if we can pick up congenital heart disease, other congenital anomaly early, then only we can reduce the IMR from 10 to below. You all know benign or innocent murmur means it will be symptom free without any other signs, and usually it will disappear in a couple of weeks time, but sometimes it may persist. The only thing you have to reassure the family, but we have to always mention and document what are the warning signs to look for. Poor feeding, breathlessness, change of color, lethargy, all these symptoms we have to document and tell to the family, because they can come back with a collapse at any time. Okay? And better to arrange an OPD. But I know especially the young generation, very anxious parents, IT people and everything, they'll be still want to know what's the answer for this heart murmur. If they're insisting, if they got affordable, if you got a facility, there is no harm in doing a echo, especially if the murmur is persisting. So pathological murmur is caused by abnormal anatomy, communication, or block, and or due to turbulent flow. You should be very careful about the red flag signs in newborn period, especially with the heart disease. Diastolic murmurs are abnormal. Continuous murmur, especially the PDA type of murmur after the closing time. Murmur with thrill. Any murmur associated with respiratory distress or signs like tachypnea or cyanosis. If they are not feeding well, if there is hepatomegaly like feature of failure, or more importantly, if we cannot feel the femoral or if it's very feeble, always worry. And beware about the terrible T's in newborn period or in the first 28 days. Tetralogy of Fallot, TGA, truncus arteriosus, TAPVC, all these terrible T's need urgent admission, urgent echo, and urgent referral to a pediatric cardiology center where there is facility for surgery. Now, what we can do to detect them early? Ideally, all this heart disease, especially major heart disease, should have been picked up antenatally. Now we got all 4D scans and everything. I know our radiologists are very skilled and competent, but how much time they are spending on doing scan? And now there's a trend that lots of obstetricians are also doing scan. So we are getting lots of pleasant surprises. All normal, but now we got a baby with congenital heart disease. When even we have to decide for palliation. I even faced such a situation last week. Everything normal. Even scanned done few weeks back. Parents thought the baby was not right, and pediatrician refers to me, done an echo. It was hypoplastic left heart with very small aorta. We sent the video to a pediatric cardiologist and they said we cannot do no surgery. So just for palliation. So that's the difficulty we are going to face. We say everything normal, expect a normal baby, starting celebration, and then now we are saying that this baby is going to die soon. So that's the importance of here. So we can do a simple thing by doing a saturation check, pre-ductal and post-ductal check separately, and low oxygen saturation 95, less than 95, or if there is significant difference of more than 10 between pre-ductal and post-ductal, could be essentially point towards an underlying cardiac disease. In our unit and in hospital, it's a routine practice that when we go for newborn check, we'll be having an ophthalmoscope, we'll be having a saturation, the Massimo portable saturation probe with us. And routine pulse oximetry is internationally proven, is an effective screening test to detect congenital critical heart disease. And clinical examination plus saturation check significantly increases the sensitivity to detect a CHT. So I request all of you, I know government is also promoting that, should be a routine part of newborn check examination prior to discharge. Respiratory, these are the signs you have to look for. Tachypnea, especially more than 60, any retractions, or if any baby got grunting or apnea, that's a very grave sign. That's a very serious sign. You have to act urgently. It can be due to respiratory problem, heart disease, chest infections, or metabolic disorders. Periodic breathing, we all know, is normal in a newborn period, especially in preterms. Now coming to red reflex. I don't know how often you include checking for red reflex as a part of newborn examination. Can you raise your hands, please? Those who are doing it? Great. At least few, okay? So it's an important and extremely useful part of newborn examination. If cataract goes undetected, the purpose is to detect congenital cataract. It may lead to permanent visual loss. In developing countries like India, 7 to 15% of the childhood blindness is due to cataract. So it's worth spending time a minute for that, because we are preventing a lifelong morbidity and disability by just picking up a congenital cataract. For significant cataract surgery to be done within 2 months of age to ensure minimal or no visual deprivation. So we have to pick it up very early, okay? Even I had a case of doctors couple born with congenital cataract. I had another case recently, the sister-in-law, when they, even before we seen the red reflex, the sister-in-law came to visit the baby and mentioned that the eyes does not look normal, because when the light came, there was some complete white thing she noted. And when we checked, it was congenital cataract. And now there are good centers, even in South India, to do surgery, and they all got very good results. So this will be the one on the top is normal, both eyes very bright red, and the one on the bottom, the one with the cross mark, it will be looking like the baby with congenital cataracts. Very simple, it's not difficult to detect. Now coming to the common problem of jaundice, we all face it a day-to-day life. It's very difficult in this, especially in this region, for SBR check and convince the parents of needing phototherapy. Jaundice appearing within 24 hours or rapidly rising SBR level, or if the baby got jaundice level up to palms and soles, or if it persists beyond 2 weeks of life, all these are pathological. You know which is the mild physiological jaundice, which you will see in normal first few days, especially gradually increasing by day 3. All these pathological jaundice need investigation, including blood test and appropriate management. I know more than anything in this region, we have to spend time to the family to explain about need of treatment for jaundice. Severe unconjugated jaundice causes kernicterus, which we all know. We assume that is not there, but still at least once a week we end up in doing exchange transfusion. And we have seen values of 20s, 30s, even 45, even referred from hospitals here. Maybe because parents didn't consent it or early discharge or whatever it is. So from home, from hospital, we have cases which we end up in doing exchange transfusion. Significant conjugated jaundice on the other spectrum got various etiologies which all need detailed evaluation and management accordingly. Prolonged jaundice in a term baby if it's more than 2 weeks, in preterm baby if it's more than 3 weeks. If it is more than 15% of the total conjugated, or more commonly used is unconjugated jaundice. It's better to arrange a follow-up in 2 weeks' time to make sure that baby is not having prolonged jaundice. Prolonged jaundice all need investigation and treatment, especially early identification of liver disease or extrahepatic biliary atresia improves the outcome. Now coming to vomiting, I'm not talking about mild reflex here, okay? On day 1, any baby with meconium stained amniotic fluid may have a little bit of small vomiting, nothing to worry. Regurgitation of feeds, vomiting soon after feeds, all due to faulty techniques, nipple problems, improper burping, anxious mothers, all these are very common. All need reassuring and nursing advice by the nurses about feeding. But persistent or projectile vomiting, bilious vomiting, associated especially with failure to pass meconium or any abdominal distension, we have to roll out intestinal obstruction. And also we have to immediately treat the dehydration or electrolyte imbalance. But also keep in mind that vomiting is not always due to GI pathology. It can be due to raised ICT. You know, babies got very soft fontanelle. It's better to just have a feel of the fontanelle. It may be a sign of meningitis. It can be due to asphyxia, sepsis, or as I said before, metabolic disorders, especially CAH or galactosemia. Hypertrophic pylori stenosis, I have seen HPS in the newborn ICU which need a surgery. Okay, we know traditionally we used to have it by 4 weeks, but I have seen in first week, I have seen in 2 weeks, and I have seen 4 weeks or after that. So it's not a dictum that it can. No, I know it commonly present by 4 weeks, but it can present before or even later. Thermal imbalance, temperature instability is an important warning sign in newborn period. It is often a sign of sepsis, hence focus need to be identified. Hypothermia is very common in sick babies, especially in low birth weight or late preterms like 34 to 37 or even IUGR babies, which is all common group we are facing in India. Hypothermia will significantly improve the morbidity and mortality in a neonate. Any cause, if the baby is hypothermic, except in perinatal asphyxia, total body cooling, in all other situations, hypothermia will significantly affect the outcome. Now, the other end of the problem, fever. Is it alarming? There is no doubt. Yes, only one answer, fever in the first few days, it's alarming, unless proven otherwise. So, which are the conditions? We know it's more than 38 degree, but sometimes it may be just a parental perception that baby is feeling very hot, but don't ignore such mother's perception. They are holding the baby 24 hours, we are just seeing for a minute. So, neonate whose parents report a clinically significant fever or we recorded more than 38 is a sign of serious infection, especially bacterial infection. Even if they do not have fever at the time of our first examination, don't ignore it. Sometimes they might have given Vamol drops and brought the baby to us. That does not mean that the baby didn't have fever before. So, these are some conditions, non-infectious cause of fever in a newborn period, but usually never on day one. Dehydration fever, very common, especially with poor feeding or due to overwrapping, especially in a very hot environment. But provided that there is no other risk factor for sepsis and babies are not unwell. So, in a well baby, no other risk factors. If the history can identify problems like dehydration or overwrapping a hot environment, we can sort these problems without doing further evaluation, provided they are well babies. But please remember that fever is an ominous sign. It can cause potentially serious complications. All fever in newborn period need admission, workup, and early treatment. And early treatment means giving the first dose of antibiotic after the basic septic workup is very crucial. If you are delaying it for a few hours time, you will not get the result because the bacteria will multiply, then will go for septicemia. Any newborn gone for septicemia is very difficult to treat them. So, coming to the skin conditions, what I want to just, what I have seen in other color codes are normal thing, harlequin changes, erythema toxicum, milia, pustulosis, all these are very common, just need some symptomatic treatment or mainly reassurance. But what I have seen, what I had noted in infections, especially the bacterial infections, viral infections, fungal infections, or even congenital syphilis, the red mark things we need to be picking up from the other color coded areas. So, to conclude, my humble request to all of you is to spend time in newborn examination and spend time in picking up the hidden dangers in newborn period, because identifying early symptoms and signs of illness in a neonate is always challenging. We need to take an extra care and extra time and extra effort. We cannot classify this as a normal general pediatric OP type of management. To reduce the neonatal morbidity and mortality, early identification and prompt and timely treatment or referral is important, which will significantly influence the outcome in newborn period. And the only slide, if you want to practice in your day-to-day life, is this slide. Have a system of having a newborn examination, have a stamp. If you have to put our signature, if you have to write, then we will look. Otherwise, we will miss. If you are especially in busy practice, if you have to see 100 OP and then you are going for a newborn check, I know there will be 100 bystanders, they will be having lunch, the baby will be crying. Lots of small factors will affect us that we will not be doing in a thorough way. So have a system and have a stamps so that before you sign, you have to tick all these areas. So you may go back and check because the baby is with you for 2-3 days. So please implement the newborn examination check stamp system in your day-to-day practice. Thank you.